Good evening, everyone. This is Dr. Renu Goel from Muzaffarnagar. The topic for the day is Umbilical Artery Doppler. Commonly used vessels for Doppler assessment in obstetrics are umbilical artery, middle cerebral artery, uterine artery, and ductus venosus. More specialized but uncommonly performed Dopplers include umbilical vein, aortic isthmus, and atrioventricular valves. Umbilical artery Doppler remains the most extensively studied fetal surveillance tool. Umbilical artery Doppler is most commonly used for monitoring and timing of delivery of the fetus compromised by FGR. Umbilical artery Doppler assesses impedance within the fetoplacental circulation. The PI and RI serve as surrogate markers for the placental vascular resistance. This is known because the number of placental arteries per high power field is lower in cases of an abnormal umbilical artery Doppler. Umbilical artery Doppler serves both as a prognostic and diagnostic tool in the assessment of growth restricted fetus. An abnormal umbilical artery Doppler waveform has been demonstrated to predict fetal compromise. So, today we are going to revise a few basic things about umbilical artery Doppler. So, to start with, learning objectives are recognize normal diagnostic waveforms of an umbilical artery, evaluate abnormal umbilical artery waveform to identify fetus with increased placental flow resistance. Its indications are maternal conditions, diabetes mellitus, chronic kidney disease, hypertension, prothrombic states. In pregnancy-related conditions, suspected IUGR, previous pregnancy with IUGR or fetal death in utero, decreased fetal movements, oligohydramnios, polyhydramnios, and multifetal pregnancy. Now, a word about anatomy and physiology. The umbilical arteries arise from the fetal internal iliac arteries and winds around the cord to the placenta. Oxygen-rich blood and nutrients flow to the fetus through the umbilical vein. Waste products and carbon dioxide flow back to the mother through the umbilical artery. This is a diagrammatic representation of the text above mentioned. Impedance. In the normal fetus, impedance is high in the first trimester and decreases as the pregnancy progresses due to increasing numbers of the functioning vascular channels as the placenta matures. Umbilical cord Doppler is not measured in the first trimester due to the normal state of high placental resistance. Umbilical artery impedance indices are calculated by using ultrasound to measure the flow waveforms from the umbilical arteries through a free-floating portion of the umbilical cord. Waveform analysis of blood velocimetry, SD ratio, RI and PI. Now a few words about the technique. Visualize the cord, select a free loop. If measuring close to the fetal body, be careful not to measure intra-abdominal iliac arteries. Keep the color Doppler window small. ROI should be longer than wider. Reduce scale in spectral analysis. Angle of insonation should be less than 15 degrees. Doppler indices measured at the fetal end, the free loop, and the placental end may carry a significant difference. The impedance is highest at the fetal end. If there is reverse flow, the umbilical artery is re-examined close to the placental insertion, as this is the last segment to develop reverse flow. Record at least 3 consecutive uniform waveforms in the absence of fetal body or breathing movements. This is a constant uniform waveform and the machine has taken the auto tracing and it has taken the correct waveform. So what you see here is the acceptable waveform, but what you see below is an unacceptable waveform. It is too condensed. There are too many pulses which are seen. So even if the machine does auto calculations, it will be difficult for you to see whether the machine has recorded it correctly. If you want to do a manual tracing, it still will be difficult for you to trace it. Ideally, you should have 6 to 8 tracings in one image, not more than 10 tracings in one image, and the spectrum should occupy the entire image of the spectral waveform so that you can analyze it properly. As you can see here, because of the movement, some tracings are very faint and some tracings are good. And if you do the auto calculation, the machine is not really calculating it properly. Even if you try to do manually, you will see that these three waveforms are at least constant. But in the manual or auto tracing, if the machine calculates the particular waveform now, it is not going to be a very correct measurement. You should see to it that you have a uniform tracing of any artery which you are insonating. Now, the umbilical artery, you should visualize the cord and select a free loop. Doppler indices measured at the fetal end, at the free loop, or at the placental end have a significant difference in their PI values. Impedance is highest at the fetal end, so that's why the free loop is always better. Sometimes, if you take it too much near the placental end, and if there are fetal parts, especially in oligohydramnios, then it tends to compress the vessel and you don't get a good tracing. But again, in oligohydramnios, it may be difficult to get a free loop. So ideally, a free loop is better, but as in some cases, like that of twins, you will not be very sure which twin Doppler is this umbilical artery belongs to. So it is always better to do the sampling towards the fetal end in cases of twins. And the PI values more than 95 percentile are actually significant of any abnormality. In the first picture, there is normal umbilical artery flow. Normal diastolic flow is seen with a normal PI. In the second picture, there is high PI. Approximately 30% villus vessels are underperfused. In the third one, there is absent end diastolic velocity. Approximately 50% vessels are underperfused. And in the last one, there is reverse end diastolic velocity. Approximately 70% villus vessels are underperfused. Now you see the fetus is breathing here and you get this chaotic type of pattern which is incorrect to trace. You'll have to wait for fetal quiescence and then take the tracing to get the correct PI value. Now in this case, you see that there was an absent diastolic flow at the free loop, but there was a reverse diastolic flow at the fetal end. So you have to be very careful. So that's why it's always better to take 3 or 4 measurements at different sites and then record the findings. Normal umbilical artery. The 40% of the combined fetal ventricular output is directed to the placenta by two umbilical arteries. The assessment of umbilical blood flow provides information on the blood perfusion of the fetoplacental unit. See, this is the characteristic sawtooth appearance of arterial flow in one direction and continuous umbilical venous flow in the other. This is the normal umbilical artery flow at 16 weeks, 24 weeks, 32 weeks and 40 weeks. Resistance in placenta fall progressively with advancing gestation. With advancing gestation, umbilical artery Doppler waveforms demonstrate a progressive rise in end diastolic velocity and a decrease in PI. These are normal umbilical artery Doppler indices. PI in second trimester is approximately 2 to 1.5. PI in third trimester is approximately 1.5 to 1. SD ratio decreases as the pregnancy advances. Like before 28 weeks, it should be less than 5. 28 to 34 weeks should be less than 4. And from 34 weeks to term should be less than 3.5. An abnormally high, that is above 95th percentile, PI value in the umbilical artery indicates impaired fetal outcome, whereas the impact of an abnormally low, that is below 5th percentile PI in second trimester, is unknown. This is a normogram for umbilical artery PI values. We can use this for our reference values. SD ratio should be less than 3 in third trimester, but this is not strictly useful because of its low sensitivity and gestational age dependence. If the SD ratio is between 3 to 5, there is placental insufficiency. If it is between 5 to 7, there is insufficiency and IUGR. If between 7 to 12, there is mild insufficiency and mild IUGR. If there is no diastolic flow, there is moderate insufficiency and moderate IUGR. If there is reversal of diastolic flow, there is severe insufficiency and severe IUGR. Normal umbilical artery waveforms. Early weeks of gestation till 12 weeks, absent end diastolic blood flow seen. Between 12 to 14 weeks, end diastolic flow develops. Beyond 14 weeks, end diastolic flow progressively increases. As pregnancy advances, there is increase in the diastolic flow and the RI is low. Umbilical artery sampling is not done in early pregnancy. In this study, a total of 100 subjects were recruited and Doppler indices measurements were performed. The ranges of SD ratio and PI from 37 to 40 weeks of gestation are shown in this table. This is a normal umbilical artery waveform at 37 weeks pregnancy with a PI value of 1.02. At 38 weeks, the PI value is 0.82. This is 39 weeks of the same patient with a PI value of 0.99. Now, at 40 weeks, the PI value is 0.97. Now, something about the pathology related to abnormal umbilical artery waveform. This is because of occlusion of the tertiary villus arteries due to thrombosis, fibrinoid necrosis or edema. Decreased number of small muscular arteries lead to asymmetrical IUGR. Why umbilical artery Doppler can be used as a screening test for IUGR? Approximately 70% of the placental tertiary villi should be affected to show changes in umbilical artery waveform, while even where 40% of the villi are affected, IUGR may be present. Abnormal umbilical artery. RI greater than 0.72 is abnormal after 26 weeks. Umbilical artery RI greater than 0.8 is always abnormal at any gestational age. PI values range from 2.0 to 1.5 in second trimester and 1.5 to 1.0 in third trimester. Any value above this is considered to be abnormal. SD ratio more than 3.5 in umbilical artery beyond 30 weeks is abnormal. Doppler waveform becomes abnormal 2 weeks earlier than abnormal CTG. Umbilical artery in pathological pregnancies. In the first one, there is high PI. In the second one, we see absent end diastolic flow, and in the third one, there is reversed end diastolic flow. Here, the Doppler ultrasound shows absent end diastolic flow in the umbilical artery. This implies increased placental vascular resistance. The umbilical vein flow is, however, normal. Axial ultrasound in the same fetus shows cardiomegaly, right atrial enlargement, pericardial effusion, and oligohydramnios. Umbilical vein flow remains normal despite clear cardiac compromise. Here, the Doppler ultrasound shows dramatic variations in the umbilical artery peak systolic velocity during fetal breathing. Umbilical vein flow is also phasic. The tracing was normal after breathing stopped. Pulse Doppler ultrasound shows reversed end diastolic flow in the umbilical artery. This implies that placental resistance is so high that blood flows away from the placenta back into umbilical arteries during diastole. If the pregnancy is more than 32 to 34 weeks, abnormal Doppler contributes to decision to deliver. In second trimester, weigh risk of hostile intrauterine environment versus risk of extreme prematurity, absent end diastolic flow, bed rest, aggressive management of maternal disease. 30% may improve within 48 hours. Improvement supports continuation of pregnancy in second trimester, and the perinatal mortality in absent diastolic flow is approximately 9%. Reverse end diastolic flow. This is quantified by ratio of highest amplitude forward flow by maximum reverse flow. This ratio greater than 4.3 without venous pulsation in free loop may support expectant management in second trimester. Perinatal mortality here is approximately 36%. This is associated with fetal demise within 1 to 7 days. Addition of venous Doppler gives more information on fetal response to adverse conditions. Now, to summarize, abnormal umbilical artery flow with absent or reversed end diastolic velocity during pregnancy is a strong indication of placental insufficiency. When absent or reverse end diastolic velocity occurs prenatally, a close follow-up or expeditious delivery should be contemplated. Absent or reverse end diastolic velocity in the umbilical artery is associated with intraventricular hemorrhage, bronchopulmonary dysplasia, and perinatal mortality. It may be associated with respiratory distress syndrome, necrotizing enterocolitis, and long-term neurodevelopmental impairment. Available data suggest that women with high-risk pregnancies such as preeclampsia, gestational hypertension, and IUGR should be evaluated with umbilical artery Doppler velocimetry to reduce the possibility of perinatal mortality and morbidity. This is a normal reference chart from 32 weeks onwards in hypertensive and normotensive patients. Pitfalls: fetal movements and fetal breathing movements will induce high beat-to-beat variability. Common sources of error are too low insonation angle, wall filter setting greater than 120 Hz, poorly defined Doppler waveform, or a heart rate outside normal limits. Transient absent end diastolic flow may be due to heart compression or due to myometrial contraction. Changing patient's position or examination after some time can show a normal Doppler waveform. It is also important to note that normal umbilical artery waveforms after 34 weeks do not exclude fetal hypoxemia and acidemia. Loss of end diastolic frequencies occur only when 70% of the placental vascular bed has been obliterated. The latter is less likely to occur after 34 weeks gestation, hence the limitation of umbilical artery Doppler at later gestations. Artifactual loss of end diastolic frequencies. A high angle between the ultrasound beam and the vessel results in very low frequencies disappearing below the height of the vessel wall filter. If end diastolic frequencies appear absent, you should reduce the vessel wall filter to its lowest setting or remove if it is possible. Then you should alter the angle of the probe relative to the maternal abdomen to reduce the angle of insonation. If end diastolic frequencies are still absent, you should then attempt to obtain the signal from a different side, because this is likely to result in a different angle of insonation. Do not report the absence of end diastolic frequencies unless this has been demonstrated on 2 successive days. Now, finally, take-home messages. Doppler velocimetry of umbilical artery provides a non-invasive measure of the fetoplacental hemodynamic state. Umbilical artery Doppler reflects impedance of downstream circulation. Abnormality of Doppler correlated to fetoplacental vascular maldevelopment, fetal hypoxia, fetal acidosis, and adverse perinatal outcome. In pregnancy complicated by FGR or preeclampsia at more than 34 weeks, that is, absent end diastolic velocity or reverse end diastolic velocity, recommend prompt delivery rather than expectant management. Thank you all for your patient listening.